Friends, we will discuss today UTI in children. I request you to watch this video till the end, and we have few beautiful case discussions for bringing more insight into this topic. Thank you for watching. Please watch till the end. Hello, I am Dr. Baljeet Maini, and today we are going to discuss pediatric UTI. This presentation is based on the latest UTI and VUR guidelines, and it is important for students that they understand what is going on in the current medical literature about UTI in pediatrics and VUR. So let us see what are the common clinical presentations of UTI in childhood. In children under 2 years of age, the symptoms are systemic and non-specific. In fact, an infant presenting with unexplained high fever has 1 in 20 chance of having a UTI. In neonates under 2 months, look out for jaundice, hypothermia, failure to thrive, lethargy, or poor feeding. In infants 2 to 24 months, unexplained high fever above 38.3 degrees Celsius, persistent irritability, vomiting, or cloudy urine are our major red flags. Once a child is over 2 years old, they can localize their symptoms. Lower tract infection or cystitis presents with dysuria, urgency, maybe daytime incontinence or suprapubic pain. Upper UTI or pyelonephritis shifts to high-grade fever with chills, flank pain, vomiting, costovertebral angle tenderness, and an overall sick look. To establish a confirmed UTI, we must satisfy the diagnostic crucible: the clinical symptoms plus pyuria plus significant cloning growth on culture. Crucially, never treat asymptomatic bacteriuria with antibiotics. Conversely, remember that 10 to 15% of true UTIs, especially non-E. coli infections, may present without pyuria on urine analysis. Cultural confirmation remains our ultimate standard. Let us understand the latest rules of the game. The 2023 guidelines of ISPN and IAP represent a paradigm shift: precision over panic. We start broad with strict diagnostic criteria to rule out contamination, move to targeted, evidence-based antimicrobial treatment, and apply a rational imaging protocol that protects the low-risk majority from unnecessary radiation while catching a high-grade VUR and renal scarring with utmost accuracy. How you collect urine detects the diagnostic accuracy. Let me be very clear: adhesive urine bags are invalid for culture diagnosis. They carry an unacceptably high contamination rate of 30 to 80% and should never be used to confirm a UTI. In toilet-trained children, a clean catch midstream is appropriate with 5% contamination rate. In sick, non-toilet-trained infants, use transurethral catheterization or suprapubic aspiration. SPA remains our gold standard, bypassing periurethral flora entirely with a 90% success rate under ultrasound guidance. On dipstick screening, we commonly perform leukocyte esterase, which detects pyuria with 79% sensitivity, while nitrites detect bacterial conversion with 99% specificity. Combining both yields roughly near 85% sensitivity and 90% specificity. There is a clinical caveat for infants. Nitrite sensitivity is low in infants because they void frequently, leaving insufficient bladder incubation time for bacteria to convert nitrates to nitrites. Do not withhold treatment in an asymptomatic infant under 6 months purely because the nitrites are negative. This is our threshold pyramid. This pyramid shows the cultural cutoffs based on invasiveness. Suprapubic aspiration: here any growth on culture roughly corresponds to 10 to the power 3 cloning following units per ml and is taken as a sign of UTI. Whereas down below in transurethral catheterization, the required pulmonary count is more than 10 to the power 4 per ml. In the clean catch midstream sample, the threshold is set to be more than 10 to the power 5 cloning forming units. So, this is the thing to remember, that we should always interpret our culture reports according to the method of urine collection. How to manage a case of UTI? Once UTI is confirmed, route your treatment logically. Uncomplicated cystitis needs only short duration, maybe up to 7 days of oral antibiotics. For febrile UTIs or pyelonephritis, ask, is the child under 2 months, septic, toxic looking, or unable to take oral fluids? If yes, admit for intravenous antibiotics. If no, oral antibiotics are equally effective at preventing renal scarring in stable children over 2 months of age. So, what are the antibiotic protocols? For acute febrile UTI or pyelonephritis, complete a total course of 7 to 10 days minimum. I personally give pyelonephritis treatment minimum 10 days. First line empiric choices include a third generation cephalosporin or amoxiclav combination. Always, like other infections, follow the rule of clinical response. More than 90% children improve within 48 to 72 hours. We should not try to chase the paper. That means the reports. If the child is clinically improving, stay the course even if the sensitivity suggests otherwise. If there is no clinical response by 72 hours, we should order an immediate ultrasound and repeat urine examination to rule out other complications like pyelonephritis or abscess. A common question comes, what is the radiology involved in UTI diagnostics? So, we have to have a right scan in the right time frame. In the initial time frame, the current guidelines say that we should perform an ultrasound in all the cases of UTI number 1. If there is no response in UTI, upper UTI in the first 2 to 3 days, and also as a part of routine screening for VUR after the UTI has subsided. Week 4 to 6, that is the post-inflammatory window, perform an MCU only after 4 to 6 weeks to avoid false positives for VUR caused by acute ureteral inflammation. After 3 months, that is month 4 to 6, a late DMS scan is performed for post-infection to assess permanent renal cortical scarring. The role of renal ultrasound. Renal ultrasound is a safe, radiation-free, and indicated after the first episode of UTI in all children. It screens for congenital anomalies of kidney and urinary tract, CACUT. Look for hydronephrosis, pelvic calyceal dilatation, or bladder wall thickening. Keep in mind its limitation. Ultrasound cannot reliably detect very low-grade VUR or very fine cortical scars. MCUG is the gold standard for anatomy. MCUG or micturition cystourethropography is the gold standard for grading vesicoureteral reflux and examining the urethral anatomy. Because it is invasive and uses ionizing radiation, and because VUR is present only in a third of UTI cases, wheel limits is used. So perform MCU only if the baseline USG is abnormal, or if there is a history of recurrent UTIs, or if the UTI has been caused by a non-E. coli organism in a child below 2 years. DMS scintigraphy, the scar detector machine. An acute phase DMS scan within 2 weeks is not recommended because it cannot distinguish temporary acute pyelonephritis from permanent scarring. Late phase DMSA at 4 to 6 months is the true gold standard for detecting permanent scars and is reserved strictly for recurrent UTIs or confirmed high-grade VUR. This is the imaging modalities matrix. To summarize, our imaging matrix shows renal ultrasound to be having zero radiation indicated for all children after a first UTI in the current guidelines. MCU is a radiation-filled procedure performed 4 to 6 weeks after abnormal USG in a case of recurrent UTI or non-E. coli under 2 years. Late DMS scan has moderated amount of radiation performed at after 3 to 6 months for recurrent UTIs or high-grade VUR. So now we can understand what is the paradigm shift. Our overarching philosophy here is maximum yield with minimum harm. We ban the adhesive bags to prevent false positives, prefer oral over IV antibiotics in stable children over 2 months to prevent cannula trauma, and restrict the invasive imaging like MCU and acute DMSA to protect low-risk children. Evaluation of recurrent UTI. The role of VUR and bladder bowel dysfunction. VUR occurs in roughly 1/3 of the pediatric UTI cases. However, you must evaluate every patient for bladder bowel dysfunction also. Constipation mechanically compresses the bladder, causing urinary stasis and elevated intravesical pressure. BBD actively delays the spontaneous resolution of VUR and is a major independent predictor of UTI recurrence. Let us briefly cover VUR grading architecture also. From a very low grade VUR, that is a non-dilated ureter. Grade 2 is some dilatation of ureters with normal renal pelvis. Grade 3 is mild to moderate dilatation of ureter and pelvis. This is the transition to high risk. So grade 3 onwards, it is a high risk for recurrent UTI. Grade 4 and 5, moderate to severe dilatation and tortuosity with loss of papillary impressions, carrying the highest risk for permanent renal scarring. This is a summary of VUR management on evidence-based escalation. We manage VUR using a 3-tier approach. Tier 1 is active surveillance for grades 1 and 2 without bladder bowel dysfunction, requires no daily antibiotics and just close clinical monitoring. Tier 2, which needs continuous antibiotic prophylaxis, that is grade 3 to 4. These are the high grades VUR. It is also indicated if a child has any recurrent febrile UTI with bowel bladder dysfunction and receives daily prophylaxis like cephalexin, trimethoprim and other drugs recommended for continuous prophylaxis. Tier 3 is having a surgical intervention approach, grade 4 and 5 primarily. Basically now the surgery is reserved for cases with recurrent breakthrough febrile UTIs despite strict prophylaxis. In some cases, surgery may be done when the parents feel that the continuous antibiotic prophylaxis is not the desired thing or the recurrent UTIs trouble them so much. So this is the complete clinical flow chart like age-specific clinical presentation, pristine urine collection, culture confirmation, oral or IV treatment routing, baseline ultrasound, restrictive MCU indications, and targeted VUR prophylaxis. Now let us go through some common clinical cases. So we can have a case of UTI coming as a sick infant, a case which has bladder bowel dysfunction symptoms, or a case with recurrent UTI. Let's apply this blueprint to 3 classical clinical scenarios you will encounter on wards. The sick infant. Here, the patient is 4-month-old male and uncircumcised and presenting with 2 days of high-grade fever, vomiting, irritability and toxic look. On examination, the child is not doing well, is lethargic with flank tenderness. So what are our key diagnostic steps here? You can pause the video here and think what are the answer to these questions. So because the infant is non-toilet trained and sick, we do not use a non-invasive bag, perform a transurethral catheterization or a suprapubic aspiration ideally. On dipstick, we do the leukocyte esterase and nitrite test. A culture cutoff of more than 10 to the power 4 calorie-forming units on catheterization confirms the diagnosis. So in this patient, I admit the child for IV third generation cephalosporin due to lethargy and poor intake. Once the child improves, de-escalate to oral antibiotics to complete a course of 10 days and then perform a renal ultrasound after the patient is near discharge. Case 2. This case is a constipated child with bladder bowel dysfunction, a 6-year-old girl who is toilet trained and presenting with dysuria, urgency, suprapubic pain and hard stools every 3 to 4 days. She exhibits holding maneuvers because of constipation. On examination, she is afebrile with a palpable fecalith mass in the left iliac fossa. So the questions here are, what syndrome ties her bowel bladder symptoms together? The answer is bladder bowel dysfunction. And how this impact her UTI risk? You can pause this video to think over how the constipation can cause UTI. So the diagnosis of lower UTI in this case is secondary to bladder bowel dysfunction. Fecal impaction mechanically compresses the bladder, causing urinary stresses. Collect a clean catch midstream urine sample as the child is toilet trained and is non-toxic. Initiate a short course, 5 to 7 days course of oral antibiotics and immediately start bowel management. Long-term treatment of constipation related UTI is to treat bladder bowel dysfunction and prevent recurrence using the 4 pillars of urotherapy. Number 1 is behavior modification of scheduled voiding and proper posture. Second is hydration optimization. Third is high fiber diet. Fourth is medical intervention using agents like polyethylene glycol to disimpact and maintain regular bowel movements. Third case is a recurrent UTI toddler. This is a very common presentation in OPD and we get routinely cases like this. Case 3 is a 3-year-old male with a high-grade fever of 39 degrees Celsius and right flank pain. This is the second febrile UTI in 6 months and no imaging was done after the first episode. So here we have to understand the UTI process going on. 2 episodes of febrile UTI classified this child as a case of recurrent UTI. The primary concern in VU are allowing infected urine to flow backward into the renal parenchyma, risking the permanent scarring. So the required imaging algorithm in this patient is first a baseline KUV ultrasound, second is MCU after 4 to 6 weeks of treatment to grade the VUR, and phase 3 is a late phase DMS scan after 4 to 6 months to check for permanent cortical scarring. We should never perform an acute phase DMSA. So if the patient is a high grade VUR, first line management is continuous antibiotic prophylaxis. Surgical rescue is via ureteral reimplantation surgery or endoscopic injection is reserved strictly for breakthrough febrile UTIs despite strict prophylaxis. So always use this master synthesis of urine collection matrix. For sick infants, always use catheter or suprapubic aspiration. For afebrile stable patients, toilet trained patients use the clean catch midstream. And always match the culture interpretation to appropriate culture colony forming units threshold and method of collection of urine. So the case 1 presented with non-specific signs requiring IV therapy and a baseline USG. Case 2 was a classical bladder bowel dysfunction requiring oral therapy and urotherapy. Case 3 presented with recurrent febrile UTIs driven by VUR requiring the full radiology, that is the ultrasound, MCU, and DMSA sequence and prophylaxis. So, the key takeaways from the 2023 guidelines of ISPN and IAP are: ban the bag, never use adhesive bags for culture diagnosis, always treat the bowel, never to miss on bladder bowel dysfunction to protect the bladder, and follow the sequence of radiology for evaluating or diagnosing VUR. So, in summary, an age-specific clinical evaluation, pristine urine connection, culture-proven diagnosis, targeted short or long dose course therapy, selective risk-based imaging are the cornerstones of modern pediatric management. So, thank you for your time. Practice evidence-based medicine, optimize your diagnostic steps, and we should always remember that we should always be remembered for good. Thank you.